All right, and let's get started. Welcome everyone to today's webinar. My name is Emily Clark. I'm pleased to be your moderator for today's session. I'm a knowledge broker at the National Collaborating Centre for Methods and Tools, coming to you from Hamilton, Ontario. We're located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. I am joined today by Dr. David Buckridge from McGill University, who will present an evidence-informed vision for a public health data system in Canada. Before we dive in, there are a few housekeeping items to cover. We recommend using a wired internet connection if you have one available for the webinar today. For best results, use the latest version of Google Chrome or Firefox internet browsers. And if you do have any technical difficulties, please send a private message to Alana Miller at the NCCMT, and we will be able to respond to those requests as they come up. After today, the slides and recording will be available in usually about 2 weeks. The recording will be posted on our YouTube account. And we will also send out tweets when they're posted, so you can keep an eye out on our Twitter at nccmt.ca. This is one case where there will be a recording in French, as this webinar will be held in French in 1 week's time as well. We have just a few polling questions to get us started, to give us a sense of the audience that is joining us today. First, we're interested in seeing how many people are joining us. While many people are still working from home, if perhaps you are back in the office and watching with a group, we would like to capture those numbers. We're also interested in whether our audience has previously visited the NCCMT site or used any of our resources. And if you have, whether you're a new or occasional users or perhaps an NCCMT veteran, please select your responses for all 3 of the questions and then click submit for your answers. And I'll just wait a moment while all those answers come in. That's great. Thank you so much. All right. Before I pass it over to David, I would just like to introduce our sister centers. The National Collaborating Centre for Methods and Tools is one of 6 national collaborating centers across Canada. We're hosted at McMaster University in Hamilton. Our goal is to support public health professionals and organizations integrate evidence-informed decision-making into their work. The National Collaborating Centers, or the NCCs, are all funded by the Public Health Agency of Canada. We each focus on different priority public health topics. From the West, there's the NCC for Indigenous Health in Prince George, BC, the NCC for Environmental Health in Vancouver, the NCC for Infectious Disease in Winnipeg, the NCC for Healthy Public Policy in Montreal, and the NCC for Determinants of Health in Antigonish, Nova Scotia. Here at the NCCMT, we do have many products and services to support public health professionals in engaging in evidence-informed decision-making, or EIDM. This includes a registry of methods and tools with over 270 resources, online learning opportunities that include our 12 online learning modules, workshops, Public Health Plus, which is a repository of public health research, various video series, including our Understanding Research Evidence videos, which go through concepts important to research in these short and easy to understand videos, and also our networking and outreach activities. In terms of today's webinar, Canada's Chief Public Health Officer, Dr. Theresa Tam, has released her latest report back in December on the state of public health in Canada, titled A Vision to Transform Canada's Public Health System. This year's report describes the impacts of the COVID-19 pandemic and provides a vision to transform the public health system in order to be better prepared for the next public health crisis and to help all people in Canada to achieve better health. To inform the development of this report, the Office of the CPHO had commissioned 4 independent reports to allow broader dissemination of these reports. The NCCs partnered with the authors like Dr. Buckridge and the Office of the CPHO working together to make sure that these were publicly available in both English and French. So in addition to Dr. Buckridge's report, which we will be talking about today, there is a report led by Dr. Margot Greenwood from the NCC for Indigenous Health, and Dr. Evan Adams, the Deputy Chief Medical Officer of Public Health at Indigenous Services Canada, on visioning the future for First Nations, Inuit, and Métis population and public health. There's also a report by Dr. Kate Mulligan of the Dalla Lana School of Public Health at U of Toronto on strengthening community connections and exploring the future of public health at the neighborhood scale. And finally, there's a report by Dr. Erica De Riguero, also from the Dalla Lana School of Public Health at the University of Toronto. And this one's on governing for public health, governance options for strengthened and renewed public health system in Canada. So Alana will post the links to the CPHA report and those supplemental reports in the chat window. And I am now delighted to introduce today's presenter, Dr. David Buckridge. David is a professor in the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. His research focuses on public health and, in particular, automated surveillance to detect disease outbreaks and guide public health interventions. His research involves the development of methods for conducting and evaluating automated surveillance, and his practice centers on implementing automated surveillance systems. So with that, I will now hand it over to David. So I will stop sharing. And David, it's all yours.
Great. Thank you very much for that introduction, Emily. And I will, without further ado, hopefully share my slides and get things going. Here we go. So there we go. So full slides. So I know there was some comment was made that slides were blurry. I hope they're looking a little clearer now for folks. Or anyway, folks have any issues seeing the slides or with the resolution, please let us know and we'll try and see if we can straighten that out. Oh, great. Good to hear. Okay, thanks, Catherine. All right, so let's get started then. So I'm going to start, as Emily mentioned, this is one of 4 reports, and I'm going to start out by getting right to the answer. So this is the last slide I'm going to show you, and I just want to place this in front of you now so that you can sort of start to think about this, and we'll build up to this again. So what I'm showing you are essentially the recommendations coming out of this report for what needs to be put in place to establish a pan-Canadian public health data system. And this will make a lot more sense at the end of this talk, but just to get you thinking right now, there are some enabling components that have to go into place. You see them listed on the left-hand side. They fall into categories of system structure, social and human components, IT and informatics components, and some overarching considerations. And I'll explain what this means as we go through, but just to get that big picture in your head, I'm going to build up for you why we need to have these components in place. And in here, what I'm actually recommending is how to go about doing it. So to put that system structure in place, we need to have some common goals amongst all the groups that will participate in a pan-Canadian public health data system. We identify the value propositions for all of those participating entities, and there needs to be a governance model. In terms of social and human components, we need to conduct public engagement to establish trust in such a system. There needs to be a broad strategy developed to enhance data and digital skills so people can interact effectively with the system. And we need to establish mechanisms to leverage academic industrial expertise to complement that exists already in the public health sector. In terms of IT and informatics components, we need to encourage coordinated digital transformation, and I'll explain what that means, and develop a roadmap to interoperability so that public health systems or data systems can speak to one another and exchange data. In an overarching sense, there's a need to identify which organization would provide leadership and technical expertise in putting in place such a pan-Canadian system. And of course, there needs to be a phased implementation plan for it. So I'll come back to this, but this is sort of the punchline, if you will. I just want to put this in front of you now, and then we're going to back up now from there, and we're going to build up to this. So establishing a pan-Canadian public health data system. The talk is divided into 4 sections here. Why? So why would we want to have such a system? We'll go through some background and some conceptual foundations for the report. Where are we going? So, what would such a system look like? That's the evidence-informed vision. To get to that vision, what has to be in place? When we talk about these kinds of systems, we can talk about enabling components. So what are the components that would enable such a system to be in place? That's the what. And then finally, what I just finished or just showed you is going to be where we're going to build to, which is the how. So how do you establish and ensure that those enabling components are in place? So that's really the sort of the actions that have to be taken to put in place those enabling components so we can reach the vision. So that's how the talk is built up here. So let's start with the why, the background conceptual foundations. So as Emily mentioned, this is in fact a report that was commissioned by the Chief Public Health Officer, Teresa Tam, to inform her development of her 2021 report, which is shown in the upper right corner here, in which she provides a vision for a strengthened public health system. And so this was really trying to go deeper into this issue of what does that mean around pan-Canadian, or the ability to have a data systems that are interoperating across the country to support public health. Also important background, as many of you are probably aware, is that this is not the first report to have looked at this issue. There are many previous and ongoing efforts to describe limitations of public health data systems in Canada. I'm showing some of the examples on the right in terms of sort of screenshots of the report. So obviously the SARS report, or that David Naylor wrote, Learning from SARS. Also a more recent report in 2015 from the Council of Canadian Academies around more generally health-related data. And then in an ongoing sense, another example is the Pan-Canadian Health Data Strategy, led by Vivek Goel and others at Public Health Agency of Canada. So this report draws on these experiences, but it's not trying to go back and understand what went wrong in the past. It's really looking forward. So trying to build that vision and understand how do we get to that vision. But nonetheless, I can assure you that those reports have been considered. And if you look at the full report that I'm summarizing in the presentation today, you'll see the linkages to those activities. So another important area of background, or what are the sort of conceptual foundations and methods that went into building this or developing this report. So there's three, I would say, sort of conceptual areas that are fundamental here. One, of course, is public health. And I've framed a lot of what I discuss in terms of public health in the context of essential services, which includes research. There are different models for going about this. I've used somewhat the model that's developed or been put forward by the US CDC, which is quite similar to the model used by the Pan American Health Organization, but there are other frameworks. Most of them have very similar components, and I show that in the top right. The other area is biomedical informatics, which is really the discipline that understands how we use data, information, and knowledge and evidence in practice, and how we generate that from data. I'm using data in the context of this report in the broadest sense to encompass all of those concepts: information, knowledge, and evidence. And another important aspect of biomedical informatics is the understanding of the need to have interoperability, or have systems, data systems that can speak to one another or work together to create a more coherent whole. I'm showing in the bottom right, actually, a diagram that just illustrates the linkage between how in public health, particularly surveillance, and also in public health research, we collect data, we analyze that data to create information. When we talk about practice, you go down more the left side of that diagram on the bottom right of the slide, because you use that information to make decisions and take actions. Whereas in public health research, we're generally using that information we've analyzed to create generalizable truths or knowledge. So there's quite a bit of overlap there, but just to be clear, we're using data to encompass all of those activities. The final conceptual framing or area is systems theory, which provides for us a framework for considering how different entities or organizations across the country can work together effectively. In terms of how the methodology used to develop the report, there was a scoping literature review done and a series of consultations, and I encourage you to look at the report, particularly the appendix, for details of the methods that you're interested in, and if all the supporting citations are in the report as well. Okay, so that's the why. So hopefully everybody understands why we're here, what we're trying to do. So I was tasked or commissioned to create this evidence-informed vision and then describe how it could be put in place at a relatively high level. So what is this vision that we arrived to? So the vision is stated, it's a little, I think, succinctly in the first part, but then elaborated in these three sort of subcomponents of the vision. So at a high level, Canadians should be able to access the data they need to make the best decisions to improve public health. So the right data in the right place at the right time. And that should happen through these three sort of ways of functioning, if you will. First of all, we should have coordinated interoperation of independent systems. And these systems are the ones that are operated right now by many different entities around the country, within and without the formal public health sector. And controlled by different organizations. And so those need to interoperate effectively to provide Canadians with access to the data they need to make the best decisions. That interaction and that access to those data has to happen in a context. Now, I think that context should be a shared understanding of the essential public health functions. So if we don't all have a common understanding of what we're trying to do together, it's very hard to have a world or a system where we allow the data to be exchanged to accomplish those functions. And then finally, regardless of where the data or the expertise might be within the larger system, there needs to be the ability for organizations to access that data and that expertise in the time delay needed or relevant to getting the work done to perform an essential public health function. So access to the right data at the right time in the right place, there's coordinated interaction of independent systems based on a shared understanding of public health functions and in a way where people can access the data and handle the capacity that they need, regardless of where that exists in the system. So that's the overarching vision. So to get to that vision, what do we need to have in place? These are what I've called the enabling components. So those components can be broken down into three different areas, which are very similar to what you saw on the first slide I showed you. We have, first of all, system structure components. So what are the elements of how we structure a system that can support that vision? What are the social and human components to support that vision? And what are the information technology and informatics components that need to be in place? And I'll step through each of these in turn and discussing some of the evidence that supports putting in place these different components. So first of all, system structure. Many systems, I think everybody would agree, with data relevant to public health functions operate independently across different sectors and levels of geography or hierarchy within Canada. And this is perfectly appropriate. And this represents the nature of the country in terms of the federation. And it also represents, to some extent, the nature of public health, which is collaboration across many sectors. There's the formal public health sector, non-governmental organizations, other entities that have a stake in public health, for example, like clinical healthcare systems, and they all contain data that are relevant to public health. And so the vision and the enabling components recognize explicitly that it is not feasible nor desirable that all of those data be brought into one large database in one place. In contrast, what really should happen is that these data systems must work together to have an effective public health data system in Canada. And so if we think about this, and the crazy network diagram on the right side of the slide is meant to illustrate this, what we really have is a complex system right now of many different public health data systems, and I use that term to refer to systems holding data relevant to public health, that operate independently. And we want to be able to ideally engineer these systems to work together in an effective, what's called a system of systems. And so a system of systems defines a large-scale integrated system composed of independently operated subsystems which are networked together for a common goal. In this case, the goal being to accomplish essential public health functions. And this may sound like a grand scheme in some sense, but there are many good examples of very complex, large-scale systems of systems that have been engineered in just this way. Not specifically in public health, but in other areas. For example, in the report, I dig into this example of global Earth observation systems, which is such a system of systems. But there are other examples, and the systems of systems engineering literature suggests that there are important success factors to make this sort of a thing work. The first is that all of the entities or organizations, data systems, have to have explicit and shared goals. So they all have to have clear goals that they're all trying to accomplish together. They also have to have a shared overall system governance. So this is not something that generally will emerge naturally from these individual systems. There needs to be some conscious effort to engineer that overall, develop and engineer that overall governance. And finally, every organization or entity that participates in such a system needs to have a clear understanding of the benefits to them of participating. And I'll come back to that. But these are really the key factors that have been shown in the literature to make a system of systems like this work. So those are the system structure components. Next, social and human components. The first thing to be very clear about is a pan-Canadian public health data system of the nature I'm describing is what's called a socio-technical system, where social and human components are critical to its success. So it's not really about, it's obviously it is important to have the right information technology informatics, which I talk about, but it's really the interaction of people with and society in some sense with this information technology in the context of a governance that really allows a system to operate and be effective. And so we have to really be clear about what are these enabling social and human components. One is clearly public engagement and trust. That is necessary for data sharing and for political will to go into the activities that would have to happen to implement and make such a system work. It's very clear from similar sorts of activities in other countries that the engagement must be broad and meaningful if you're going to establish public trust in such a system. And when I say broad, I mean that must include many communities across Canada. Given the particular nature of Canada, Indigenous communities obviously must play a very central role in the development and governance of such a system. The second enabling social and human component is trained personnel. We really need people with the skills needed to build up a system and effectively interact with a system. It's widely recognized we need those skills, and it's been so for many years, but there have been relatively few advances in developing or advancing these skills at the pace and in the way that we would like to see in the country. And when I speak about those kinds of skills, I mean skills particularly in public health crossed with data management and analysis, effective use of new digital technologies, and data governance and sharing. So yes, we want expertise specifically in those areas, but ideally also expertise in those areas with people who also have expertise in public health, which is really critical for applying those kinds of skills in a public health setting. So this is a bit of a description of what some of the really important enabling social and human components are to be able to realize a system. The last set of enabling components are around information technology and informatics. So if we're talking about networking together independent systems, it's important obviously that those independent systems, if they're going to interact with a larger system, they must be able to effectively capture, store, and interchange data in a standard manner. In public health, however, we know that many data systems are outdated and they provide somewhat limited functionality, in which you might say they're not exactly fit for purpose. And this creates a technical debt, which is a term that suggests that you're carrying along a bit of this sort of technical baggage that really stops you from going forward at the pace you'd like to. And that needs to be addressed. As a good example, there was a study done in late 2020 in the United States of public health organizations, and it looked to see what was the main barrier to them exchanging data with hospital systems around laboratory results and so on. And the main barrier was the inability of the public health organizations to receive the data. They did not have the technical capacity to receive, store, and manage the data. I'm sure the situation is probably very similar in Canada. And I know there have been similar descriptions of limitations in Canada. So the point here is that if you want to have a networked sort of system of systems, those independent systems have to be fit for purpose. And we need to think carefully about what that means. Assuming you do have systems that can be networked together, then the way to think about going forward in the framework that I'm presenting here is a federated approach. And what this means is, again, that you don't take all of the data out of the individual systems that you think is important, try and specify it a priori, pull it out of those systems and put it into one large database. That's challenging for many reasons, in terms of governance, also in terms of agility. The strategy is to leave the disaggregated or micro data in the data systems where they're collected, where people have control, if you will, governance, or they're stewards of those data. And then analyses are allowed to visit those data, perform the necessary analyses, and return results to somebody else. And so it really becomes then, in this federated model, a way of sort of opening up your system to others when they also open up their systems to you. And that provides them with benefits and you with benefits. This has been shown to be very effective in some disciplines, such as pharmacoepidemiology and in genomics. The example I quote or look at in the report is the Sentinel system for pharmacosurveillance in the United States, and the C-nodes network in Canada is quite similar. So there are really, I think, quite good proofs of concepts for how to go about this. One of the challenges, however, is though that with this federated approach, if individual systems want to, in a sense, open up their systems or some aspect of their systems, they don't have to, of course, reveal all of the data in their systems. They want to have a firewall or a barrier and expose certain types of data. They have to format that data usually in a very standard manner, and that can be a heavy lift for some organizations. So one strategy to support individual organizations this work is something called a brokering approach, where a third party can be brought in to help facilitate, in a sense, that mapping or translation, if you will, of data from what one independent system, how they may store their data, and then how other systems want to access it. And that's in fact what was used in the GEOS, or the Global Earth Orbiting Systems example that I mentioned on an earlier slide. So these are the critical IT enabling components. So then to summarize these enabling components, as I mentioned, in three areas: system structure, social and human components, and IT and informatics components. For the system structure components, we need to have explicit and shared goals among system participants, shared governance, policies, and financing, clear perceptions of benefits so people understand what they're going to get out of participating in the system. On the social and human components, we need public engagement and trust, and we need trained personnel to interact with the system. In terms of the IT and informatics components, we of course need single systems that are fit for purpose, or able to collect, manage, and interchange data. And we need a mechanism for effectively networking these systems together. And I've proposed that a federated approach is a encouraging or promising direction to go in. Okay, so those are the enabling components. Now, the big question is, how do we get there? So if you accept the vision and you will agree that those are the components that we need in place to realize that vision, how do we put those components in place, establish them, and assure them once they're in place? So again, I'm going to go through these three components, and this is building up now to that very first slide I showed you. So we have system structure components, social and human components, information technology, informatics components. I'm adding a fourth area here: overarching considerations that don't cleanly fall into one of those areas, but must be addressed when we think of the implementation aspect of what I'm describing. So again, I'll step through each of these areas, and then that will bring us to a close. So establishing system structure. So recall, what we're trying to put in place here are goals, governance, and clarity about benefits. This is where I come back to the essential public health functions. This, I believe, can provide a clear foundation for establishing the goals for a pan-Canadian public health data system. Anything that system should do should be in furtherance of achieving essentially the capacity for participants in the system to more easily accomplish those essential public health functions. Of course, greater precision is needed if a system is to be developed around this, and so you'd want to dive a little deeper into those essential public health functions, and that would allow us to identify more precisely what are the data system requirements to accomplish those functions. And this does not need to all be done at once, but somewhat of a broad look should be taken, I think, so that all functions are looked at, not just the assessment functions, which tend to be looked at the most when it comes to data, but in particularly research also needs to be included, because that's an important public health function that is somewhat orthogonal in some ways to some of the more practice-based functions. The other important aspect here in terms of putting these enabling components into place is that the value of participating must be clear. So although this approach is really about networking or putting together existing independent systems, resources are required, both in terms of the governance and in terms of modifying individual systems. And so the value proposition has to be clear to the funders and the participants. That value may differ across stakeholders. So it may be different, for example, for a provincial health authority as opposed to a municipality, as opposed to a non-governmental organization, but it should be grounded in facilitating their ability to perform the essential public health functions. Finally, meta-governance requires resources and organizational capacity. And so there needs to be some commitment of resources and some organizational leadership in terms of putting in place this structure. Resources would also likely need to be made available to individual organizations, as they would have to adapt their planning and operations to participate in a larger system, but of course would retain their independence in terms of how they actually manage and govern their own operating data system or public health data system. So those are the sort of the what has to happen, or some important things that have to happen to put in place the system structure components so that we have goals, clarity of governance, and benefits to the participating or possibly participating entities in a pan-Canadian public health data system. Okay, in terms of establishing the social and human components, so here we're talking about engagement, trust, and skills. Engagement obviously needs to occur with a broad range of stakeholders, and that engagement should really probably center around transparently developing, communicating the goals and the values of the system. I think it's been shown fairly clearly that trust and data sharing requires the obvious compliance with existing privacy and security laws, but also a very robust set of practices and policies that are built in a sort of a engaged way, if you will, with all the stakeholders. And given the nature of this system, the stakeholders really include the broad Canadian population. A broad training strategy also needs to be developed that goes beyond current core competencies to address skills needed in data analysis, management, and digital systems. And we need to think here about innovative mechanisms that can support the effective use of digital technology. So I think this kind of a strategy has to look at within public health sector, academic partners, commercial partners, and other sorts of things like supporting not-for-profit agencies that can really help public health organizations, if you will, up their game or improve their capacity in this area. Interestingly, too, we're also seeing around the world a move both in countries like the United States, also in Europe, and at the WHO level to try to leverage capacity from research and commercial partners as they try to modernize their public health system. So recognizing that it's very hard to have the sufficient expertise and often the real cutting edge expertise that you might need to innovate entirely within public health organizations. And so this opens up the possibility for creating partnerships either with academic organizations or with certain commercial partners, whereby there may be the possibility to have expertise move in both directions that would facilitate the achievement of public health functions. And finally, I say more about this in the report, but information blocking must be addressed. Information blocking refers to the tendency for organizations to limit access to data, even though that data access is legally allowable. And this can happen for a number of different reasons. The United States has been fairly aggressive in this area, trying to pass legislation to block information blocking or prevent information blocking, particularly by information system vendors. But just to point out that this is really, I think, fundamentally the solution here is not one of legislation, but it's one of understanding. And so some thinking has to go into how to advance the sort of the culture, if you will, around how we share and use information. So those are the social and human components and how we really want to, ways to try to put in place the components we need for a system. So on the IT or information technology informatics side, I'd say what we're trying to put in place here are these robust independent systems and have them be interoperable. So as I mentioned, considerable investment is going to be required to address the technical debt. It's unlikely this would happen all at once, but if it did, it would be sort of like a New Deal sort of investment, if you will, to really try to revolutionize or transform public health. And what's interesting about that is that there is a move underway, I think, around the world, led by WHO to some extent, but also OECD and others, around digital transformation in healthcare. And a significant investment in public health information could really drive a digital transformation in Canada. And the idea of thinking behind a digital transformation is not that you just use digital technologies to automate what you're doing, but you take a step back and you think about what you're trying to accomplish, and you essentially think about a process redesign, if you will. How can I do this better using what digital technologies are available to really facilitate this work? And there are good examples of this happening already. I referred to in the report, for an example, in Australia, of how they took the opportunity of COVID to essentially digitally transform and redesign their contact tracing process. So there's an example where, again, they started from thinking about what do we have to do, looked to see what tools are available, and developed a process that really didn't just automate manual methods, but made the best possible use of digital tools to accomplish the public health objective. If this kind of investment occurs and that kind of transformation happens, it could really drive an evidence-based convergent evolution. So that means letting independent public health data system operators, they understand the evidence. If they're making changes to their system towards where we want to go, if there's sufficient guidance and leadership, that could push us towards better interoperability and facilitate a smoother interoperation among systems in the future. The second big change is to move towards a federated model from a centralized hierarchical approach. So, right now, as I mentioned before, what we really have in public health data is a movement where we have the most disaggregated data usually at the local level. And then as it moves up from the local level to the provincial, territorial, and the federal level, increasingly you get less and less information. And the legislation and structures that allow those data to move are very rigid and not terribly agile. And so a federated model provides a bit more of a flexible strategy where we have a data governance that clarifies who can access what data for what purpose. And then we have put in place these messaging and data standards, including a common data model so that we can all kind of map our data to the same schema, if you will, or map of the data that's relevant to public health to coordinate things. And then, of course, there are also methods available for privacy preserving methods that allow you to link data across those kind of distributed systems or federated environments and also perform analysis across them. So some of this technology is still developing, but a lot of it is quite mature. And so this is another sort of component of what we could do in terms of how we could make these systems talk to another is to move towards a more federated model from a centralized hierarchical approach. Okay, now finally, the overarching considerations that I mentioned. So as I stated in the background, the awareness of shortcomings of public health data systems in Canada and in fact globally is not new. We obviously can learn lessons from previous reviews and experiences. For example, I think Panorama, the experience of Panorama after SARS, highlighted the need for shared goals amongst participants, which was apparently not really the case, I don't think, across provinces and territories in that context. The need for agility, so to be able to move quite quickly as things on the ground change, and the model used to develop Panorama was not one that was terribly agile. And also we want to have strong public health leadership. And so public health people were obviously very engaged, but in some sense, in that example, the system planning and development was handed off to another entity that did not have a lot of public health expertise. And so, we need to be very aware of those lessons as we move forward. And I think one of the most important considerations coming out of that is that technical expertise and leadership in public health informatics and other disciplines related to what we're talking about, and they are quite broad, is needed to drive development and implementation of a pan-Canadian public health data system. So how could that technical expertise and leadership be brought to bear, if you will, on this problem? 3 models have been proposed. The first is that we would use existing federal, provincial, territorial structures, of which those are very well defined. Post-SARS, that's the structure essentially that led us to the creation of the Public Health Agency of Canada. So we know it can work, it can make things happen effectively. And of course, it also engages provinces and territories, which is very important because they're key players in what we're talking about here. But that process can be slow and it can be influenced by short-term political considerations. The second model that people have suggested is to adapt an existing pan-Canadian organization that could provide this sort of technical expertise and leadership as we try to move towards the vision I've described. So Canada Health Infoway and Panorama is one example, which I mentioned, which we learned some lessons from that experience. Another possible example is the Canadian Institute for Health Information, which presents a promising operational and governance model for how provinces, territories, federal partners, and others can work together both in governance and also data sharing. So that's one possible model. The third model would be to create entirely new organization, as we saw occurred with the Canada Blood Services in Quebec after the commission that looked into the issues around contamination of blood supply. Now, that is something that has been done in other countries. New organizations focused on public health data have been created. There are some possible benefits there, but we also need to be careful with not creating an entity that's disconnected in some sense from public health, or one that has a broader remit, for example, health data in general, and then public health issues may be not as at the forefront as they would need to be to develop such a pan-Canadian public health data system. So those are the overarching considerations. So to summarize, and now we're right back at the start, this is the first slide I showed you. What are the, essentially what needs to be done to establish and assure these enabling components for a pan-Canadian public health data system? My recommendation or suggestion is that we need these components around system structure. We need to clarify common goals. So what are those common goals? And my suggestion is that those be grounded in essential public health functions. We need to identify the value proposition for participants. Because individual organizations or entities will need to modify their systems, put in resources and so on, it needs to be clear to them what they're getting out of participating in this larger pan-Canadian system for them to take part. And we need to develop a governance model. So, what is the governance of such a system? How is it determined who can access what data for what purposes, and how participants would approve those access conditions. In terms of the social and human components, we need to conduct broad public engagement to establish trust in such a system. We need to obviously develop a broad strategy to enhance data and digital skills, so we have people who are available and able to work with and develop such a system. And I think what's probably going to be helpful is establishing mechanisms to leverage academic and industrial expertise to bring some of that expertise into public health. Now, of course, recognizing there is considerable expertise in public health, both in terms of data management analysis, but most importantly in terms of public health. And so it's really about not having people from academia and industry come in to save public health. It's really about creating meaningful partnerships there to have bi-directional flow of knowledge and skill. In terms of IT and informatics components, to enable those, we need to encourage coordinated digital transformation in independent systems. And that would require, as I said, some degree of investment. It's not something that has to happen immediately, and it can happen over time. It could occur in a convergent way, as I described, through some process of digital transformation in public health. And then we need to develop a roadmap to interoperability. And what that means is understanding where we are right now in terms of how public health data systems can or cannot interoperate, exchange data, and where we'd like to be, and laying out a plan for how we want to get to a situation where those data systems can effectively interoperate in the context of a governance model that we put in place. And then finally, overarching considerations. If we want such a system to be in place, we'd have to identify an organization, either an existing one or a new one, to provide leadership and technical expertise to drive forward the process. And this could all, of course, not happen at once. The idea there would be to develop a phased implementation plan where we could look at what are the sort of really winning use cases, if you will, or what is the highest value proposition in terms of the essential public health functions, build a sort of a prototype, if you will, around that. And then if that goes well, you can expand from a pilot. So that's the kind of recommendation, if you will, about how to go about this in an overarching way. So that's the summary then, in terms of the implementing these components to enable a public health data system. And with that, I will, there we go, end the formal part of the presentation. I will be delighted to take any questions if there are.
Wonderful. Thank you so much, David. That was a really, really fantastic presentation. Really appreciate you taking the time to present with us today and providing that really valuable insight into what it would take for a system like this. I have seen a number of questions come in. So what we will do for the session, for the Q&A section of the session, is I will read the questions to David for him to answer. We'll take them in the order that they have come in. The first one is more of a comment from Hazabullah, more that one more area would be public health evaluation to appraise health system performance. David, would you like to comment on that?
Yes, and that's a great comment. Thank you very much. So you're right. I mean, one aspect of improving the performance of any system, of course, is being able to measure the performance, measure what that system's doing and what the outcomes are it's achieving. We do a reasonably good job of that in the healthcare delivery system in terms of health services outcomes research. In public health, we don't do such a great job. In fact, we do not systematically capture what we do in public health, which I've always found somewhat boggling. If you think about that, that'd be like in the clinical care system. We have patients that come into the hospital, we write down what they have, but then we don't write down what we do, and we treat them and let them go. How would you ever know how effective those treatments are in a real world sense? And so that's not, I mean, that's maybe the caricature, but we're sort of at that level in some way in public health. I know that this is a priority. The Institute for Population Public Health, the CPHO, sees this as important. I know others do as well in the Urban Public Health Network. And so there is work I know underway in Canada to try to improve our footprint, if you will, in terms of how we measure what we do in public health and how we understand how effective that is. So I think in the context of what I presented, that would need to be certainly one of the essential public health functions, really, is in fact system improvement. And so thinking carefully about how we measure data what we do and measure the effectiveness of what we do is very important for any system framework going forward.
Great, thank you. The next question is, where can we refer to the CIHI operational and governance model? I believe CIHI referring to the Canadian Institute for Health Informatics, I believe.
No, Canadian Institute for Health Information.
Thank you, yeah.
Can I put this in the chat to everybody? Yeah, okay, I'll put in a link in the chat then just to that website. There you go. So that, sorry, I've lost who asked that question. That was anonymous. No, that was Nicole, sorry. So Nicole, I've just put that URL into the chat.
Great. And then the next one, several reports have suggested the idea of a learning health system for Canada, most recently from the Canadian Institute for Advanced Research. How would this Canadian public health data system relate to a learning health system?
Well, a learning health system is a really interesting model, I think, where we talk about, for those that aren't familiar with this model, this is a model where we talk about this cycle where we collect data on performance, we analyze that data, turn into knowledge, and then we take that knowledge and we push it back in the system to hopefully improve performance. And you can think about that cycle occurs with a community around it. And so, critical to any learning health system is data and how you can access, analyze that data. And so I think what I've described is a fairly high level framework, but you can imagine how it would support those kind of learning cycles that might occur across different geographic locations. So right now, for example, local health departments operate but for the most part independently and without a lot of communication across provinces and territories. You could imagine through such a federated system I described where you might be able to network with or find other local health departments that are working on similar problems as you, and they might expose certain data about their process to you. And so you could learn from one another. And so, I think this ability to share data more effectively through or across public health jurisdictions in such a way could really support, I think, that kind of learning healthcare system or learning public health system model in this context.
Thank you. Next is, what are the key data systems that governments should work on making interoperable first?
Yeah, I hesitate to prioritize that right now. I think that goes back to the phased implementation I described, and I would suggest the answer to that question comes from a very careful analysis of essential public health functions and their data requirements. And what is the incremental value of accomplishing that public health function to access data from somebody else? So, for example, you might imagine where you're trying to estimate certain parameters, for example, around infectivity or something like that, or disease transmission. Very hard to do with a small amount of data you might have in your jurisdiction, but if your analyst could access similar data across other jurisdictions that may have actually seen more cases or in a previous wave or something like that, you could then have sufficient data to do that. So that would be kind of the rare event analogy of where it makes sense to get access to more data. So that, that's one example, but I would think you would want to look at the essential public health functions, understand the data requirements, and be able to make an argument. I think my sense is that the assessment functions will probably be the ones where that use case is the easiest to make in the short term, but there might be others.
Great, thank you. From Ruth, post-SARS, we had a FAC-led online learning opportunity to skill up public health staff in epidemiology. Can you imagine a component of your vision where we skill up in digital transformation?
Yeah, that's a good point, Ruth. I certainly can. And I think the point I was trying to make, though, is that we need to have a broad strategy. So I think, and we need to think clearly about people coming into the profession of public health, people already in public health settings, and the ways they come in, So there's been a lot of focus on MPH programs, but people come into public health from many different areas. And so, how do we think about addressing that with our training partners? But as you mentioned, Bruce, some degree of online learning, I think, is critical for people in the public health system particularly, but also people coming from other sectors.
Great. Have you encountered any research analyzing the development of these networks in terms of maximizing entropy?
Yeah, I don't have a good answer to that one. I'm sorry. That sounds like a bit more of a theoretical question around network theory, and I don't have a good answer. Sorry.
That's okay. How do you work with jurisdictions who are unwilling to share their data?
Well, I think that all comes down to the value proposition. So, I think for somebody to share their data, they have to see value in sharing their data. I think, there is some degree of sort of goodwill, if you will, that, if it's going to help you and it's not, an undue burden for me, I might do that for you. But if there's clear value that is returned to me for sharing my value with you, then I think that's the way to make the case. And so I do think the best way to sort of facilitate data sharing here is to clarify the value of data sharing. And there is some theory around this. And I do refer to that in my report, where there's some analysis around this data sharing in particular, if it's done well, can actually save a fair bit of effort for individual public health organizations.
That's great. From Louise, who do you think should take the leadership to elaborate your very interesting 4-part model?
Well, I presented 3 possible strategies there at the end. I think it could, ultimately, this is something where the provinces, territories, and federal government need to play an important role. But the question is it one of those entities or an existing federal, provincial, territorial structure that's the best suited to do this, or is it some other entity? That wasn't my remit, really, is to say exactly how it should happen. And so there are different ways it could happen. And I don't really want to commit to one being better than the other. I think there's pros and cons amongst all those. There's also the question of, what's the most likely to happen on the ground. My one point I'd like to make about that, though, is that I would hate to lose the sense of crisis that we're in right now, and the recognition that we do need change, because we know how slow it can be to make these things happen. We saw what happened after SARS with the best of intentions. It took a long time to make any change to public health data systems, and the impact was, I would say, mixed at best. So I think it's really important that this momentum continues. And there are entities. I think the Pan-Canadian Health Data Strategy is one effort, which is led by the Public Health Agency. Canada has other partners, which is well positioned, I think, to keep this line of thinking moving forward.
I'm going to switch over. I've noticed a couple questions coming through the chat, so I'm watching the timestamps to make sure we take them in order. That's okay. So just trying to make sure I get them in the right order here. From Lauren, thank you for the presentation, Dr. Buckridge. How does your proposed data system align or differ from how healthcare data is integrated for research purposes through ICES?
Interesting question, Lauren. Yeah, and so I think you could think of ICES as sort of a data enclave in a sense. So that is one in one province, Ontario. They are an entity that has the legal authority to bring together data sets and link them. So in other provinces, some of the provinces have similar entities, other provinces don't, but you could think of ICES essentially as one entity that could be a node within a larger network. Now, of course, that would require a governance model and might require some changes to the ICES governance model. So this is something that would, you'd have to think about down the road. But I think entities like ICES or ICES, sorry, in other provinces as well could provide similar roles. And so, in some sense, from a research perspective, where we're going with things like HRDN is going in a very similar area. You think about not centralizing data, having data stewards or enclaves, and then having clarity about the process through which you can access or get use of those data. Now, the difference of what I'm talking about is more real-time systems here. So I think in a research context, it's essentially what you might consider an offline system, where every time you want to access something, you put in a request, you get, there's a process, you make it a little, at ICES, for example, they have a process where you can access the data from a distance and analyze it. What I'm talking about more is sort of operational public health systems, where these data exchanges would need to be automated. And so the governance model would need to be clearly articulated for the operational data exchange, exactly as happens in many sectors of clinical care, finance, and so on. This is not something that's new. It would just need to be articulated in a new way for public health.
All right, and from Jan, the notion of information blocking is very important to unpack. Sometimes a group holds on to it to publish work, other times politically. This is a very important other consideration that you mentioned. Any ideas on how to tackle this?
Yeah, well, I think the most important is to understand the motivation for the blocking in the first instance. And I think the work that's been done in the United States has identified different motivation in different sectors. So, for example, information systems vendors have an incentive to block access to information because they feel there's a value in those data, and they want to be remunerated for access to those data. In the public sector, it's often more about risk aversion, and either risk aversion in terms of concerns about, the data might be released inadvertently or inappropriately, or that somebody might analyze the data in a way that makes a finding that is uncomfortable, if you will, for the data steward. And so I think, better understanding those motivations and then thinking about ways to address them. As I mentioned, in the US, they've tried to put through legislation to really address the vendor side of the issue, and it's been not terribly successful, I would say. So this is an open problem. I agree it's important, but I think really the first step there is to understand the motivation in a Canadian context, because I think data exchange and data privacy is somewhat different here than the United States, and think about solutions.
Great. We have a longer question in the chat from Dan. Does the report make specific recommendations around small organizations, like smaller than a health unit? I'm thinking about, for example, the homelessness sector. Many smaller organizations have data that could be used to support public health decision-making, but many are essentially doing the best they can with an Excel spreadsheet. For some, this works fine. For others, it is not, and they would like to use more formal or flexible tools. They may not even see themselves as public health data holders, even though in aggregate, the data from these many small organizations across the country could be providing incredibly important information. Technical capacity building in these smaller organizations may itself be a public health intervention if it helps them operationally, besides just providing support that they should be getting anyway, but it may need to look different than supporting, say, a health unit.
Yeah, couldn't agree more, Dan. That's a great point. And I think I described an approach that, for larger public health entities, fits in with their data management and systems management sort of frameworks. But for smaller organizations like the one you described, it really can be quite a challenge to think about how they would interoperate with such a large system. That's why I think that I brought up the topic of brokers, which is sort of an approach that's been used where you actually could have, as part of your central governance model, you could also support these third parties called brokers which could help smaller organizations and larger ones, but perhaps, you could even have different foci, if you will. Some brokers really focused on smaller organizations to facilitate getting their data translated to a format and vice versa that would allow them to interoperate. And that, that brokering could be offline to some extent. And I think exactly as you point out, Dan, that brokering could also have an element of skill enhancement as part of it.
Thank you. And in the chat from Harpa, is the scope of the public health data system limited to data collected for healthcare or public health purposes, or inclusive of other data that may inform public health? For example, self-service providers' data or travel industry data. Is so-called big data outside of scope?
I haven't really put any limits on the data. I think the foci are the public health functions. So if you can connect those data to performing a public health function better, then I would say they're in scope. In fact, such an approach as I've described, I think works very well with big data, quote unquote. So, you could imagine, I know cellular service data is a little bit in the news these days in terms of the federal government, but you could imagine a cellular service provider creating an interface, an application programming interface, for example, that public health entities that are part of this larger system could access in a way that had certain constraints on it and could be used to pull data and push it into, for example, their disease transmission modeling. So again, this is I think Harp, I think your point is thank you for raising that. I think that is definitely within scope and fits well, I think, with the framework that's been put forward.
Great. Back to the Q&A. From an attendee, I would completely disagree with the statement that we don't document in public health for Ontario public health units. We do track all visits with our public health clients and are mandated by ONA, the Ontario Nurses Association, and privacy legislation to do so. I actually think we do a great job. The issue is that we have such old systems that we are often recording our visits and interactions with clients multiple times in both ministry mandated systems and then EMRs that were paid for because the ministry systems are so old. I would say that if we streamlined our systems and updated them, it would improve documentation efforts and free up more staff time for client interactions.
Okay, great. Well, I completely agree with your complete disagreement, because I was not talking about individual care delivery when I spoke about that. I was talking about more public health programming. So in fact, in many provinces, they don't do a lot of individual healthcare delivery in public health units. But what I was referring to, for example, are programming around chronic disease control, you name it, the full gamut of what public health does. And while some health departments do record what they do. My point is that we don't record what is done by different public health actors or entities in a systematic way such that it can be centralized and analyzed to understand and derive from that real world data evidence about what works and what doesn't work. That's what I meant. And so I don't think we do a very good job of that in any province in Canada. But the point is well taken that in provinces that do deliver individual patient care within a public health setting, I do agree with the comment from the attendee that those interventions are documented. I was using the clinical care delivery as an analogy for public health programming and service delivery. And I was saying that we don't really apply the same degree of rigor to capturing the interventions done in a public health programming way as we do to capturing the interventions delivered for individual clients, whether it's in a public health setting or in a clinical healthcare delivery setting like in a hospital.
From Mohini, using the proposed approach, how can data quality processes be implemented / measured?
Yeah, well, data quality is a huge issue. That was not really addressed explicitly in the report, but obviously it's part of, if you're going to be interoperating and exchanging data, it's a very important element of the data is to understand the data quality. I mean, ultimately, we'd like to get to the level that we're ISO 8000 compliant, and in terms of data and so on. But that's a long distance to get to. But I think when you think about data exchange, there would have to be certain quality checks that would be put in place. And in fact, the way to get there, which is I think the way that many frameworks talk about this, is to make sure that we don't just exchange data, but we also exchange metadata, which are data about the data. So this goes back to the standards and the common data model I described. So for example, if when you transmit data, you transmit the metadata about the limits and the ranges and the acceptable values and all that as a separate format, then people can actually take the metadata and the data, and they can do some kind of quality assessment on the data directly themselves. And so I think that's the direction probably to go in the future. But again, this is something that would take some time to build out, particularly across the breadth of public health functions.
Thank you. From another attendee, in the HI/HIM world, it has been identified many times that Canada needs a broader system. Do you think following this report and pandemic, this will remain a political priority?
I hope so. Hard to predict things, especially the future, as the famous saying goes. But I think this is the important next step coming out of both the Dr. Tam's report and the supporting reports for it is, how do we really move these forward? I know it's challenging, particularly in the current environment that seems to be the never-ending pandemic. But I think we definitely need to think carefully about how we pull together these different threads and push it forward.
From Janet, how can we locally build support for moving this forward?
Well, I think there's all of the changes we'd like to see in terms of public health data systems and maybe even public health more generally have to be driven by support from the ground up, and so I think this comes from local public health and provincial territorial public health entities wanting to do this, and so I think this is not something that can be imposed on the groups that would take part. It really needs to be which is kind of, I think, very interesting about this strategy. It's no longer really a hierarchy. It kind of flattens it a little bit, and it becomes an opportunity for information or data exchange amongst multiple peers, almost a peer-to-peer network in sort of a way. So I guess to go back to my points, though, one of the kind of things that could help with this would be to begin to have some discussion and engagement with the broader public. Ideally, that would happen in the sense of some movement towards building such a pan-Canadian public health data system. But I do think having some discussion and then starting to build out a bit more of the vision would help.
From another attendee, making decisions based on the information related with public health are ultimately political in nature. Given that such decisions have a particular bend, what are the chances that there will be political buy-in for any strengthening of public health, including proposals as this?
Well, I agree that ultimately decisions are made by elected officials, which is what we want. And those elected officials try to balance data and evidence from public health and other sectors with other considerations, and they try and make a decision that they think is best for the population. So, you know, decision making is inherently political by politicians, not surprisingly. Now, at the same time, I think a lot of both federally and provincial, territorial, and even municipally, public health entities and governments have seen the value of good data and timely data and analysis applied to those data. So, you know, I certainly know, speaking, you know, in Quebec, where I do a lot of my work, I've seen a major shift in the provincial government here in terms of their appreciation of timely, high quality data and analyzed model data around public health decision making. And so maybe I'm too optimistic, but I'm somewhat optimistic that there will be receptivity for building a strategy out that will make that kind of data and information analysis available more quickly. You know, obviously we have to deal with these issues around information blocking I described before and sort of, you know, lack of trust, but I think they are potentially addressable.
How do we recruit the best talent where tech experts expect a much more modern and agile workplace than the comparably archaic governmental workplaces?
Well, yeah, I mean, this is an ongoing concern. So, you know, and I think this is occurring in a lot of public sectors where it's challenging to create the same remuneration as you might experience in the private sector if you have those skill sets. And I think we just have to stop trying to compete at that level. There are other benefits to working in government and you know, public health settings. But I do agree that you know, and this was my comment about digital transformation and a bit of a, you know, making systems fit for purpose. There does need to be a recognition that's probably mainly at the recognition and allocation of resources, mainly at provincial territorial level, but, you know, could be supported by federal funding to really work on improving those environments. But I think it also reaches back to the training stage. So, you know, I found through the work that I've done with students and undergraduate, graduate students that, you know, the more they learn about application potential for some of this methodology and the ability to make a difference in a way that they can, you know, be happy about, that attracts, you know, not an insignificant proportion of people who might have otherwise gone into, you know, more commercial endeavors. So, you know, I think it's about modernizing the environment. It's about, you know, making clear the benefits and going a bit up the supply chain, if you will, to try to let people appreciate the potential benefits.
Great, thank you, David. You've done amazing. This is like rapid fire. I'm so impressed by the engagement of the audience.
Yeah, great questions. Thank you.
Yeah, really. From another attendee, I'm happy that Dr. David spoke about establishing that shared understanding of needing such a system for essential public health functions to be carried out. First Nations and perhaps other Indigenous bodies continue to struggle to access various databases. That interoperability aspect is needed, but it becomes tricky when there is ambiguity between various levels of government and their responsibility to support public health functions for First Nations. It creates barriers. Can Dr. David comment on this, specifically the involvement of First Nations in this work while adhering to the OCAP principles of data governance?
Yeah, and I called out specifically Indigenous populations, so First Nations and Inuit Métis communities as being really important for helping to develop and operate the governance and the actual such a system as I described. And so the attendee mentioned OCAP there, which is a set of principles that really, you know, have been created by First Nations groups in Canada to really define ownership, how it's important for First Nations to have ownership and control of their data. And I think actually this federative model, you know, fits very well with that. So, you know, First Nations communities, well, all Indigenous communities, you know, in theory could be the holders of their data about their community. And the governance model could be defined that would you know, allow access to those data under certain conditions. And also reciprocally, they would be able to access data from other communities, Indigenous or not, in terms of that governance model. I think it goes back also to the question there, though, about capacity and how we set that up. And, you know, these are not trivial. For sure, there are important issues to address, but I think that, you know, that kind of framework can work very well. Now, how exactly to engage with First Nations and other Indigenous communities in this work? I would point to the report that you mentioned, Emily, by Margot and Dr. Evan Adams, or Marguerite and Dr. Evan Adams. And there is a section there, in fact, on health data. And I think it's very interesting, obvious. And what I found most interesting about that section in their report on health data is it takes a very broad perspective on health data. And so, what constitutes health data from a First Nation perspective may be somewhat different than the way that I might think about it, for example. And so I think we need to explore that full breadth and understand, what that means, both from a governance perspective and a technical perspective. And that can only work with meaningful engagement throughout the process with those communities.
Thank you. I've got one more question in the Q&A, and I think one that I missed in chat. So first, how can the public health workforce enhance their capacity in data and digital skills expertise?
Yeah, that's that broad strategy I mentioned. I don't have a simple answer for that one. I mean, we've tried a lot of different things in Canada, in other countries. I don't think there's a silver bullet. I think it does go back to, engaging with schools of public health. There is a forum for that. I think it also goes back to this concept of perhaps skills enhancement through online learning for people who are already in practice, perhaps. There are other sort of more, I think I referred to a couple examples in my report. One is, for example, the US CDC created public health informatics fellowships. So kind of based after their EIOS, or Epidemic Intelligence Service, or Field Epi program we have in Canada, but created one of those just for public health informatics. So get a cadre of people who are trained up in this area, and then would go out and work in different settings, and then ultimately be, kind of brought into the public health systems. That's one example. Another is, funding not-for-profits that build expertise in this area and then can work as resources for public health organizations. Moves it a little bit outside the government. So the Public Health Informatics Institute in the US is one example of that kind of an entity that's funded mainly by the US CDC, and then provides that kind of technical support to health departments.
Sorry, question I think I missed from chat earlier from Vanina. Thank you for sharing. My question is to know if these components could be applied to low and middle income countries' health systems.
Yeah, I mean, there's nothing specific about the Canadian context at a high level here that I'm describing. I mean, obviously this is very grounded in the reality of our federated nature here in Canada. And, depending on the country and the way the health system and the public health system is structured, there might be simpler solutions. What's nice about this model, though, is that it retains some degree of control and ownership at a lower level. So, that can support more sort of community organizations and so on. Although the flip side, as Dan pointed out, is it does place a bit of a technical requirement on those organizations then to participate. But as I pointed out, the concept of digital transformation, including digital transformation in public health, is something that the World Health Organization is supporting for low and middle income countries. And so, thinking about digital transformation in the context of public health systems is certainly something that is definitely applicable in low and middle income countries. And then this framing around how you might create, kind of a countrywide public health surveillance system, or public health data system, sorry, could be relevant depending on the way the country is structured.
All right, thank you, David. I think we've actually made it through all of the questions. There's definitely some interesting discussion in the chat. Before we wrap up, though, I will take us through a couple of closing slides, a few more things that we wanted to cover. And I will pull up our slides for this. So David, you can take some time to go through the chat and see if there's anything that you wanted to pull out from there. But in the meantime, thank you so much. Really, really fabulous presentation and such an engaging discussion section. Really fantastic. So before we wrap, we are always interested in learning about how evidence-informed decision-making is being used in public health, how it's being applied, especially now during the ongoing pandemic and the constant challenges that we're facing. We are also available on the flip side to support for evidence-informed decision-making. Feel free to reach out for us for help. We're available to support through practice questions, consults, tailored webinars, workshops, and partnerships. We're really open for anything for discussion, and we'd be happy to talk through any ideas or needs that you or your organization has. Now, we would greatly appreciate your feedback on today's webinar. This allows us to make sure that our webinars do meet the needs of our audience. So we please ask that you use the polling features, just like you did before, to answer the questions. Make sure that you hit submit or make sure that you click to submit your answers so that all of the responses get recorded. I will wait a moment to let everybody respond. I do see answers coming in, which is fantastic. We still have quite a few people with us, which is great. I think it speaks to how engaging that discussion was. Some really great questions there. And they're still coming in. Thank you so much. I know I learned a lot. I think the links to the reports have been linked a few times now in the chat windows, and really well laid out and thorough reports. So I do encourage anybody who's interested to take a quick look at those when you do have a chance. So that's good. So moving on. For other webinars from the NCCMT, I will first highlight that this webinar will be held at the same time next week on Wednesday in French for our Francophone partners. And if you are interested in any more of our webinars, as well as upcoming webinars on the topics from the other reports that accompanied the CPHO report, you can visit our webpage and follow us and the National Collaborating Centers on social media. If you have any trouble finding anything, feel free to email us, and we certainly hope to see you at some future sessions as well. And with that, I would like to once again thank Dr. David Buckridge for this excellent presentation and really valuable discussion. If you have any further questions about this report, the NCCMT, or any of the NCCs, don't hesitate to reach out. We're happy to make any connections for you. I do wish you all a great rest of your day. I'll pass it on to you, David, for closing. But from me, thank you so much, and take care, everyone.
Well, just thank you, Emily, and the team at NCCMT for hosting, and to all the attendees, thank you very much, and have a great day.
Thank you so much. Take care.